Hello, everyone. I'm back to share with you one of our quality improvement projects in the hospital, which is reduction of blood culture contamination. So, a quick background on why blood culture contamination reduction is important in an organizational setting in the healthcare is that it leads to unnecessary antimicrobial usage with the potential for adverse events and selective pressure. Next is unnecessary additional patient care measures, profound impact on costs, increased length of hospitalization, and the potential for needless hospital admissions. And lastly, unnecessary utilization of laboratory resources. So thinking about lean methodology, if you got a contaminated blood culture, that's already a waste because unfortunately you need to repeat the test, or else the patient will be needing to get unnecessary antibiotic therapy. So, as you know, emergency department is very busy, high demanding place to work in the hospital. And of course, as frontline, you get a lot of patients from all kinds of setting. So there's a lot of factors that come into play when it comes to blood culture contamination in the emergency department. So in the organization that I am in right now, we measure this metric apart from the inpatient setting. So historically, we run we, historically our blood culture contamination rate runs around 6% pre-pandemic. So pre-COVID, it was in 2019. It's around 6% at most. So it may run on an average of 4% contamination rate. What does it mean? So we run around 1,200 blood culture tests per month. That's approximately 30 to 40 tests of blood cultures in a day. And we target a 2.5 contamination rate. That's around five, five sets, five sets in a day. But we are in the emergency department, we are having more than that. So we are being flagged, or not really flagged, but we are challenged to lower it down because it's one of the metrics. If we are going to look around and see what the CLABC committee is working on and gearing forward, so we tried to challenge that, bring it down. So during that time, when I was not in the hospital yet, there was a team that was formed, which is composed of multidisciplinary, which is composed of laboratory, infection prevention, staff nurses, phlebotomy, quality improvement. So those are the team that was made up to and tasked to lower down this contamination rate. And what they did is they found, they checked literature, they checked the practices of the other hospitals, and they have gone through and considered several interventions. They thought about using diversional supplies when drawing blood samples, but they found out that these diversional supplies are costly. Um, Also, through structured problem solving, they found out that nurses express this frustration of having supplies in separate places. So the supplies needed for proper skin preparation is are found in different places. So they have come up to developing a blood culture collection kit. So that has been developed and ordered. However, the order was delivered several months later. And yeah, we found improvement in that, but of course there have been drawbacks, pushbacks from the users, but that has been um, that has been dealt with on a timely manner. Significant reinforcement every day that yes, this practice has been proven to lower it down. This is effective in lowering the blood culture contamination with the use of chlorhexidine wipes. Yeah, so that improved, but I think the significant piece of lowering the metric is having the data in hand. So when I came when I came to start on this project, I checked on the data and saw the pattern of where the contamination is, where it happens, what patient care areas it happens. Is it in the resuscitation area? Is it in the pediatric side? Who are the nurses who have high contamination rate? Who are they? And what sources? Is it from a central line, from a peripheral IV? And yeah, so I checked it. I check this data on a daily basis. I request more data from the laboratory as needed. And and I think what really impacted this endeavor is to notify on a timely fashion these collectors that yes, the sample that you collected turned to be contaminated. They have no recognition of that before, so they don't have that opportunity to evaluate whether or not their practice is correct. So having this timely feedback that, oh yeah, someone is checking, or yes, thank you for letting me know that the sample I collected is contaminated, and in the future I'll be more careful. So that timely feedback is really give us the correct transition towards which direction you're heading to in the future. Another thing is what else? Um, we have this discussion that maybe we can put this feedback somewhere and display it or publish or showcase it somewhere. I'm not truly, not truly, I did not prioritize that because I'm not seeing it effective, more effective rather than giving individual feedback. The problem is I feel negative, I attach negative feeling to publishing something that is um, something like that. So having individual nurses be notified individually, I think that is more effective than publishing them all together. There also, I found that having them notified individually allows them to reply to me and give them their feedback as well. So that is a surprise. And yes. So I encourage that practice if you are working on some improvement strategies in your hospital. Uh, yeah. So the last action plan, or the latest action plan that we are kicking off is based on the data that we recently analyzed, is that there's a huge opportunity to improve in reduction of the blood culture contamination in terms of the source, which is the blood, which is the central line. So I am planning to send this out, put this in the huddles or massive emails or wherever. I'm thinking of other ways to publish this, but this is a quick way on to remind everybody that please practice this whenever you have to get blood culture sample from a central line. As you can see here, um, what did you know that blood cultures from central line have approximately 3 times contamination rate as peripheral sticks, and why the susceptibility may be due to site, product, handling, or technique. So please be reminded to scrub, remove, scrub, and replace before drawing samples from existing central line. So scrub junction between catheter hub and needleless conductors, infusing cap, needleless connectors, or infusing cap using either Preventix or alcohol prep pads. So please be reminded of the wet and dry times for each. So it depends on your hospital policy on what it dictates depending on wet and dry times. Remove old connector lines, old connector from lines, scrub the hub again using again Preventix or alcohol prep pad, replace the hub. Do not waste, use the sample to fill in your bottles. And it depends on your hospital again whether or not you will be the volume of the sample and whether or not you will be extracting anaerobic from pediatrics what your cutoff age for peds. So I'm planning to send this out soon. So as we speak, it is January 11 that I will be sending this out, and I'm looking forward to reducing the rate of contamination from our central lines. So that will be all, and I hope to update with you soon on this endeavor. Thank you.